I think we have everyone from the waiting room in now, so
Okay.
others might trickle in, but I think we are good to start.
Okay, fantastic. Welcome everyone. So for those of you who don't know me, because I'm not quite sure who's on the line, I'm Heather Hedges-Tabropoulos, and I'm a professor of psychology at the University of Regina and executive director of the online therapy unit. And Emma's just going to move my slides forward to the, yeah. So on behalf of everyone at the online therapy unit, I'm really delighted to have you join us today for the World Sleep Day seminar. And before I introduce our speaker, I'd like to acknowledge that the online therapy unit's home base is at the U of R, situated on Treaty 4 lands with a presence in Treaty 6. And these are the territories of the Nehiyawak, Anishinaabe, Dakota, Lakota, and Nakota, and the homeland of the Métis Michif Nation. And at the online therapy unit, we are committed to increasing our understanding of Indigenous peoples and really respect the importance of traditional ways of healing, along with, the modern way of healing that we're currently providing. In the online therapy unit, what we're doing is bringing what would normally be shared in face-to-face treatment to clients in an online format. So we offer many different 8-week therapy courses with weekly therapist support provided typically by messaging, but sometimes phone calls. So we have a well-being course, a chronic health conditions course, an alcohol change course, a well-being course for new and expecting parents, and excitedly, we have the sleep course, which was developed by our speaker today. We also do have a couple of brief interventions, such as one on improving everyday mental health habits and another on how to support loved ones with mental health concerns. And one thing to note is that all of these services are free. So if you want to learn more about these courses, I encourage you to visit our website. You can also give us a call if you are interested in some promotional materials to, in case there's providers on the line who might want some materials, please reach out to us. So we strongly believe that we have a lot to offer clients. Move to the next slide, Emma. We've now provided assessments to over 16,000 clients with over 13,000 clients who've been treated, and it works out to about 1,200 clients a year. And clients really tell us that they value lots of things about our service. So next slide, Emma. It's free, which I mentioned before. It has initial assessment. It's all based on evidence-based cognitive behavior therapy. We have registered clinicians who work with our clients. And then importantly, there's no referral needed, super convenient, no travel required. It's private and confidential. And then we're always doing research to enhance the quality of our materials. And what this means is that when clients finish, they really say that this was so much easier than they expected, and that the materials are very well developed. And I should mention that most of these materials were developed in Australia and have also heaps of research within Australia as well. So now I'm thrilled to introduce Dr. Amelia Scott. So she's a clinical psychologist with a PhD from the University of Sydney and a researcher at Macquarie University's eCentre Clinic, where she develops and evaluates digital treatments for mental health and sleep disorders. She's also practices at the Wilcock Institute, one of Australia's leading sleep clinics. So today's presentation is a wonderful opportunity to hear all about the work that she does in the area of sleep and how important it is for us all to get good sleep and to do things that help us get good sleep. And then you'll also hear about the treatment program that she's developed and is now available in Saskatchewan. And as we go along, I'd encourage you to submit your questions in the chat. And at the end of the session today, Emma Bally will be posing these questions to Dr. Scott. And so you'll get all your burning questions answered by the end of the seminar. So on that note, thank you so much, Dr. Scott, for joining us today for World Sleep Day. And I'll turn it over to you.
Great. Thank you for having me. I'll just share my slides to start with. So, and I will start my presentation. Oh, it's starting in presenter view, isn't it? Which happens when you're connected to another screen. Let me just try and share the one that it went to properly. I'll try this one. That looks better to me. Hang on. Does that look better to you, Heather or Emma? Can you just shout out if it?
Yep,
Perfect.
that works.
Okay, perfect. Thank you. Thank you everyone for coming along. This is a picture of the sunrise this morning because as you probably know, whoopsie. Let me put that down. As you probably know, I'm coming from Sydney, which it's just after 7 in the morning. And this is North Ryde in Sydney, which is a little north of the city. We're sitting on the lands of the Wallumattagal people of the Darug Nation. And I'm getting a fire testing alert above me. I hope you can't hear that. Oh dear. Okay, I've been told that if any alarm happens from now, then I need to panic, but fire testing's done. So I'm sitting on the lands of the Wallumattagal people of the Darug Nation, and I pay my respects to elders, past, present, and emerging. And I also extend my respects to any First Nations people from the lands that you are all sitting on today in the other side of the hemisphere. So the talk I'm going to give to you today is, I think I've called it Mastering Sleep, but I'm also going to say it's kind of going beyond sleep hygiene. My understanding is that a lot of people today are health providers and maybe are likely to know a little bit about what to do to get healthy sleep. I'll certainly cover off bits and pieces as well. But I kind of want to go one step deeper. And I also want to talk a little bit about some myths and misconceptions we have about sleep. Certainly, there's been a real increase of interest in sleep, especially in the last, say, 5 to 10 years. And I think along with that, there has become a little bit of concern or kind of over concern, almost perfectionism about what sleep should and shouldn't look like. And I kind of want to help people to arrive at a healthy relationship with sleep and understand what sleep is when it's good enough or when it's normal. Because I think a lot of us are told what to do to get perfect sleep. And what's interesting in my clinical practice and as a deliverer of the sleep course, we're seeing more and more people come in with concern about their sleep because it's not what the idea of perfect or kind of perfection of sleep is. So today I'll cover what normal sleep is, and I'm also going to give an overview of some common sleep problems that we see in a sleep clinic. And then, and perhaps most importantly, I'll talk a lot about insomnia, which is the key sleep difficulty, the most common sleep disorder, and talk a lot about the treatment for insomnia, cognitive behavioral therapy for insomnia, which is the content of the sleep course offered in the online therapy unit. Before I go into the science, I think it's interesting to think about the fact that you can look at sleep through lots of different lenses. So of course, psychology and science is perhaps one of the most dominant or helpful lenses. But in recent years, I've started to think and look about sleep from the lens of history and culture, because I think that that's really interesting to kind of situate ourselves in, I guess, our cultural and our historical context. So if you think about the history of sleep and you go back, well, you know, before we even achieved agriculture, when we were kind of hunter-gatherers, we used to sleep in large groups of people to keep us safe by a campfire. Our sleep was very much governed by light and temperature. So the rise and fall of the sun was really the key marker of what to do in our days, when to be active and when to rest. Sleep was probably completely out of people's minds in a sense. It was just a necessity for survival. But going to sleep in lots of these kind of outdoor caves or near campfires under shelter was also quite a risky activity, right? Because people were always at risk of dangerous animals or opposing tribes or so on. So it was always necessary to have people awake on watch, protecting their fellow cave people. So sleep was done together, and there was never this kind of global, everyone's asleep at the same time. If you fast forward to when we started to, I guess, not have to hunt and gather, and we planted and had the agricultural revolution, families and livestock would usually sleep together, keep each other warm under the one roof. And we have a lot of evidence that sleep was what we call biphasic. So it happened in 2 phases. So what that means is people would often have their first sleep in the early hours of the night. And then a lot of people would get up, they would reflect, do kind of religious activities, housework, socialize by candlelight. And then they would have what was called the second sleep. So this all still happened in the darkness. So sleep and wake was still dictated by the sun. But there's a lot of evidence that we used to have a few hours in the middle of the night where we woke up and did things. I think that's really relevant because a lot of people with insomnia do talk about waking, say, at 2 or 3 in the morning. And sometimes I wonder whether there's kind of this ancestral middle of the night wake up gene having its influence. Where sleep starts to become really interesting is when we invented artificial light. So all of a sudden we could do so much more in the evenings. So activities at nighttime became much more common. And the theory is that the influence this had on our sleep was that it smushed those 2 phases into the one, because we started to stay up a little bit later. And our sleep for the first time perhaps became this one, hopefully continuous stretch from falling asleep in the evening to waking up. And we also start to see for the first time that the wealthy who have lots of space start to sleep by themselves. So it's the first time in our history as humans that we actually start to sleep independently, which I also think is interesting to think about because it's almost normative now that everybody sleeps in their own rooms independently, of course, with the exception of spouses. And, you know, this isn't a talk about children, but children often, I think, understandably want presence and company when they're in the middle of the night. So following the light bulb kind of artificial light movement, we have the Industrial Revolution. And this is when all of a sudden, for the first real time, we start to operate by the clock. And time, as measured by the clock, minutes and hours, becomes the way in which we govern all sorts of things that we do. And so the other really important thing that happens in this context is that lots of labor movements from around the world start to achieve the 8-hour workday. And this is based on a lot of advocacy that we have 8 hours for work, 8 hours for rest, and 8 hours for sleep. So sleep becomes this thing that has to fit into kind of quite a scheduled and industrialized society for the first time. We then get into the kind of the late 20th century, and there's what I would describe as a bit of hustle culture. So a lot of similarly kind of nuclear family predominates. Everyone has private bedrooms, and sleep in a lot of contexts, especially kind of the, you know, that stereotypical businessman working a really hectic job, sleep becomes this obstacle to productivity, and people glorify not needing very much sleep. It becomes this thing that it's really cool to go on very little sleep. And that still hangs around. I believe I've heard that Donald Trump boasts about not needing very much sleep, for example. But what has shifted a lot today is that we've become, there's a growing interest, not necessarily in going without sleep, but in trying to optimize our sleep to improve our productivity and performance. We have this expectation that we sleep alone still in one continuous block, and there is an increasingly large industry of products, devices, sound machines, mattresses, supplements, teas, etc., 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 that kind of give us the promise to give us good, perfect quality sleep. And so it's increasingly become a product. Sleep is something that we try to buy and measure and optimize to make sure that our days are we're as happy and as healthy and as productive during the day. So in short, we've gone from sleeping all together in a big group of people, family and non-family, to sleeping largely alone or with one or two others, in Western culture, I should say. It's gone from being kind of fragmented, biphasic and variable to having this expectation we have a single continuous 8-hour block of sleep. It was probably just a biological necessity, something that people had to do to stay well, and mainly thought about how they could do that safely without being eaten by a tiger, to kind of the enemy of productivity in the late 1900s, to kind of a marketable product. And from my lens, and I'd be interested if people put in questions and comments what it is like in your context, but from my lens, I'm seeing that we're starting to care much more about sleep and sleep deprivation than ever. And we hear headlines very regularly about the ills of sleep deprivation for a variety of health and mental health products. And so what I'm seeing more and more is this continuum of enthusiasm about sleep, where we used to, or at some point we kind of, there's people who sit down on one end, the kind of sleep neglect end of the spectrum. I don't care about sleep. I'll sleep when I'm dead. I'll try and get by on as little sleep as possible. Right over to this side of sleep anxiety, caring too much about sleep. There was a post on LinkedIn that was doing the rounds actually in the last few days, where someone put this post about how they'd achieved the perfect night's sleep based on all of these metrics, and said, in short, you've got to build your life around sleep. And I think quite the opposite of that. I think the purpose of sleep is to help us live. But when people start to build their life around sleep and start to get very anxious about the quality and quantity of their sleep, we tend to see that tip over into unhelpful anxiety. And anyone, which is very common, anyone who's struggled with sleep knows that the more you care, the harder you try, and the more anxious you become, the more it eludes you. So when it comes to talking about sleep, I'm always aware that there might be some people, and perhaps less people these days, because we don't actually have very much evidence for those, that there's lots of people that neglect their sleep continuously. But I'm aware that we've got to tell some people they do need to care about their sleep and protect their sleep for all of the good reasons and all of the good things it does for them. But we also need to help people understand that we don't need to worry so much, and that it really is something that happens outside of our conscious control and our attempts to kind of control or measure it or enhance it in any way. So I'll try and straddle both of the ends of the spectrum of enthusiasm today. So why you should care, for anyone who thinks that maybe sleep is just a bit of a nuisance in the way of them doing what they want to, it really is quite a vital part of our lives. We have plenty of evidence now that it promotes a variety of cognitive, physical, and other functions for our bodies. And in the last, say, 50 or 60 years, the domain or the discipline of sleep medicine and sleep science has really come to understand what function sleep serves for us, and all sorts of different features of what sleep looks like when we measure it with brain waves, and what those different sleep states deliver for us in terms of our health. So we've gone from thinking of sleep as this passive state of rest, where we essentially shut down for a number of hours overnight, to this really active state of restoration and recovery. When we actually look at what's happening in the brain while we're sleeping overnight, often the brain looks busier and more active than it does when we're awake. So especially states of dream sleep, we see the brain being kind of very noisy and having lots of different activity than kind of perhaps if we were in a restful state of waking. We know that our blood pressure and inflammation is very regulated, and it's often getting good slow wave or deep sleep that helps to support our inflammation, our immune system, and our recovery from, say, injury. We also know that certain parts of sleep, particularly REM sleep, which stands for rapid eye movement sleep, is essentially a process where any memories or difficult experiences or extremely emotional things that happened to us the previous day kind of get processed and laid down, and the memory becomes more of a kind of an autobiographical memory rather than something that's very emotional. And we suspect that there's maybe something that goes wrong in this process in the context of trauma and PTSD. And so we know that REM sleep especially helps us with regulating our emotions and helping to reduce our risk of mental health problems. But when we talk about why you should care about sleep, the question also becomes, well, what should I care about? Is it what and what's normal? What should I aim for? And it can be as simple as how many hours do I need overnight? What time should I go to bed and what time should I wake up? What type of sleep matters to me? Is it important that I get as much deep sleep as I can, or is it important that I get as much REM sleep as I can? They're the two popular types of sleep. And is it normal to wake up, or if I start waking up, especially if I'm getting older and I need to use the bathroom overnight, is that causing me harm? So I'll try and answer all of these questions in the next few slides. So we have this typical expectation of sleep, as I've kind of discussed in the historical slide, that we fall asleep and wake up about 8 hours later. And when we talk about like the average adult, probably across the Western world, that timing is around 10 or 11 p.m. and waking up around 6 or 7 a.m., knowing that there's a bit of variability around that. I'm a bit earlier than that, for example. That, if you can see, is 8 hours from 11 p.m. to 7 a.m. And I think first and foremost, it's really important that I bust the myth that we all need 8 hours of sleep. I do say to people that saying that we all need 8 hours of sleep is kind of like saying that we all need to eat 2,000 calories a day. It doesn't at all acknowledge that we all differ in terms of our age and our activity levels and our genes. And not only do I differ from you and your family and everyone else, but we differ from ourselves across time. So the variability in sleep is between people and also within people across time. So one example is that we need perhaps less sleep as we age, and anyone who, well, we've all been through childhood, haven't we? But anyone who's got children will see that as they get older, they start to need less sleep. And we know that that does seem to extend into older adulthood, although it's a much less steep of a curve. And as I have preempted, the idea that we need 8 hours and we need 8 continuous hours is more of a modern cultural construct than it is supported by proper evidence. So when you do go out and you survey adults about how much sleep they get, which is actually much harder than it looks, because we know people aren't great at estimating how much sleep that they have. But when you do, and it's also very difficult to hook everybody up to either kind of polysomnography, which is that brainwave EEG type of study, or even kind of wearable devices. But when we ask people based on self-report, the average sits around 7 hours. So I know the American Academy of Sleep Medicine, for example, I'm not quite sure if there's any kind of broad advocacy bodies in Canada, the Australasian Sleep Association, and so on. Most of these advocacy bodies recommend between 7 and 9. But I do quite wish that they wouldn't recommend between 7 and 9 with 8 being in the middle, because we know that most people are achieving around 7. And certainly when it comes to people who I see clinically, they seem to be on that slightly lower end of the sleep needs spectrum. And in many cases, it becomes this anxiety about the fact that they're continually falling short of 8 that causes a lot of concern. So that's one important thing to take home. There is a common rebuttal to this by saying, well, hang on, haven't we gone and buggered our sleep up? Haven't we gone and stuffed it up by getting less sleep than we needed back in our kind of pre-industrial days? There is this widespread argument that we are going through this terrible sleep deprivation epidemic, which is largely unfounded. We don't have much evidence, if any, to suggest that we're getting less sleep than we used to. And there are actually some studies, especially since the COVID pandemic, to suggest we might even be getting a little bit more. And one interesting way to address this concern that is, are we getting 7 hours, but we actually all do need more than that, well, we can go and look at some of the few societies left that we would define as being pre-industrial. So no artificial lighting, no kind of commercial culture, really still in hunter-gatherer organization. There's this famous study published in a very top scientific journal that went to these 3 different communities close to the equator and gave them actigraphy watches, which is a kind of a research grade wearable device to measure sleep and wake. And they looked at their sleep across a period of time and also across different seasons. And they found that these people slept on average 5.7 hours in summer and 7.1 hours in winter. So that gives us some degree of insight into what sleep looked like prior to light bulbs and agriculture and industrial revolution and so on. It also shows us how seasonal sleep is when we may be not in our climate controlled living situation, that people have historically slept less in summer than they do in winter. And that makes a bit of sense. You know, winter is where a lot of animals hibernate because food is not very available and it's cold and you need to conserve your energy. So we kind of have this really very mild version of a hibernation effect happening among humans. And in summer, when it's warm and it's light for much longer and foods are very abundant and people are social and so on, we tend to report less sleep then, and that's perfectly normal and healthy. So the question that will then often come to people's minds about, well, if I don't need 8 hours, how do I know what I need and if I'm getting enough sleep? And it's a really difficult question to answer. But in research settings, we consider someone being sleep deprived if they have a tendency to fall asleep during the day. So if this person were to sit on a long train ride, or if we were to actually put them in a controlled laboratory environment and give them, say, a 20-minute opportunity to lie down, the people who are falling asleep quite quickly, we consider to be having some sort of a sleep debt or to be sleep deprived. So if you're not napping spontaneously, you feel reasonably refreshed in the morning, but I should say not straight after waking, because we know that once we wake up, we tend to have a bit of a sleep hangover, and the feelings that we have, you know, in the first 5 to 10 minutes after waking up are often different to those we might have an hour or so later. And the other aspect is if you feel you can get through your day comfortably without a strong urge to sleep. So this overwhelming sense of I just want to lie down and close my eyes, and knowing that if that happened, you were likely to fall asleep, that's probably a sign that you're getting enough. The one thing I'll mention that's really important and often a common topic of conversation with people with sleep problems is around daytime tiredness and fatigue. Tiredness and sleepiness are not the same thing. So if somebody feels like they need to lie down, but they're unlikely to fall asleep, we're usually dealing with causes more complicated than just simply being sleep deprived, whether that's that they're feeling very anxious or that they've got an underlying health condition or kind of a nutrient or mineral deficiency, or they're going through a period of stress or so on. We know that going through the day feeling tired may not necessarily be a result of not sleeping well. It may be in some part, but we know that the biggest indicator of not getting enough sleep and being sleep deprived is being sleepy rather than being tired. So the next question is, well, what about sleep timing? You know, I said that the typical adult in the Western world is going to bed around 10 or 11 p.m. and getting up around 6 or 7. I've seen some books kind of floating around, ones I think called the 5 a.m. Club. And there's this idea that if you're getting up at 4 or 5 in the morning, you're going to be a successful CEO or something. But we know that everybody differs in terms of where their body wants to be alert and active and productive and doing its best work, and when it's sleepy and kind of foggy-headed and disoriented and wants to essentially be at rest. So we have these phenomena of the early bird and the night owl. So this top bar here is someone who falls asleep well after midnight and probably wakes in the middle of the morning. And we know that there are even extreme versions of that. So people only falling asleep at 4, 5, 6, even 7 in the morning and kind of sleeping for much of the day. And then we have the early bird who might be falling asleep at 8 p.m. or 9 p.m. and getting up well before the sun rises 3 or 4 in the morning. And so this is the kind of the language we use around these people is what's their chronotype or what's their circadian rhythm preference. And I'll talk a bit more about these types of people in terms of when it becomes a problem later on. But essentially, we know that everybody differs in where they want to be asleep and awake, and encouraging everybody to sleep and wake up at the same time is ignoring people's underlying preferences. So there are some great ways you can find this out about yourself. There's this questionnaire called the morningness eveningness questionnaire, and I think if you put that word, morningness eveningness questionnaire, that statement into Google, there's heaps of online tests that ask you kind of what you prefer to be doing at what times of the day and tell you where your preference is and also how extreme that preference is. You know, are you a mild morning person or a moderate evening person, let's say? We certainly know when we have a bit more concern about the evening people, the night owls. Often that's because our kind of 9 to 5 society tends to disadvantage these people. And but what we're seeing more and more is that people who do have a late tendency are finding that with big screens and little screens and social media and so on, it's very easy to push that late tendency even later by staying up at night and scrolling on their phones or watching things or so on. Whereas I think the theory is that we've always had people that are across the spectrum because we've always needed people to stay up late and be sentry and watch for predators and so on. We've always needed people to do the early shift in the morning, but you know, we didn't evolve with light overnight, so we didn't have people who were inherently just sleeping when the sun was up, for example. That probably wouldn't have happened. So in terms of timing, it's really about respecting your unique chronotype and where you feel your sleep phase is best aligned to give you a sense of feeling well and productive during the day. Oh, my light's just turned off. It's coming back on. So then people talk about, well, what should happen when I'm asleep? What should my sleep look like? And sometimes I get people to draw a picture of, well, say, if this is the depth of sleep ranging from light sleep to deep sleep, and this is time across here, so your total sleep opportunity, what should it look like? And people often talk about, so this bar is meant to say, well, I fall asleep, I stay asleep, and I wake up. And that I gradually dip into deep sleep, and then I gradually rise out. Now, I presume that a lot of people in the audience know different, but this is a really common expectation that people have or have been led to believe about what sleep should look like during the night. But what it really looks like, especially when you measure it on kind of through a formal sleep study, it's more like this. So most people, or some people will know that we have cycles of sleep across a given night. And in any sleep cycle, we cycle through different types of sleep architecture, different sleep stages. And those sleep stages are detected by electrodes placed all over our scalp. And then someone, or now sometimes a computer, looks at the output, the EEG output, and plots different brainwave activities against different stages of sleep. And so we know that in any one cycle, we're cycling through all different stages of sleep, ranging from light sleep to deep sleep and to REM sleep. And I've got a graph on the next slide that talks a little bit more about this. And in between those cycles, we blip up into wakefulness and we wake up. There is no person ever who sleeps completely through the night who doesn't wake up. What happens is, because we do hear people say, well, they got X amount of uninterrupted hours. What happens is these awakenings are usually quite brief and they're usually uneventful. We know that in the period just coming out of sleep and just before we sleep again, our brain actually doesn't encode memories. So we really don't have any memory of waking up, even though we do. And even though if we all went into a sleep study, wakefulness would be detected. So it's really normal to wake multiple times a night. And even the next layer of that is that if anyone goes through a sleep study, there are two different things that are coded in terms of wakefulness. One is wake, so how many times we fully kind of emerge from the surface of sleep and sometimes even open our eyes, definitely roll over and so on. And the other is arousal, so just brief movements of our brain pattern into kind of wakefulness looking brain patterns. And they may be associated with a little bit of kind of conscious awareness. And we have an arousal index, which kind of indicates the number of times arousals happen in any hour. And an arousal index of 10 or 15 is perfectly normal. So the idea that sleep is this long, continuous patch of unconsciousness, kind of like being sedated for a surgery, is really untrue, especially as we get older, which I'll show you on the next slide. So this lovely, colorful picture is actually for a kind of research article publication. It is a depiction of these different stages of sleep across a night. So this person goes to bed around 11 p.m., starts off with a little bit of wakefulness here. Then they cycle into some light sleep. This is very light sleep here, and this is kind of deeper but still light sleep. And they get some deep sleep and come in and out. We know that most people get their deep sleep in the first few hours of the evening or the sleep opportunity, and then they get their REM dream sleep in the later few hours, more likely to get that. Now, I should note that this person here, who's kind of one of three parts of a graph that I chopped off, has no sleep complaint. They have said that they're a normal, healthy sleeper. So you might be surprised to see that, well, the blue, this N3, which counts as deep sleep, there's not very much of it. And so we know if we survey lots of people, and there was this really big study done in 2004 that looked at any sleep study published ever and found all the data. On average, for a healthy young adult, we probably on average get about 20% of our total sleep time in deep sleep. And that is perfectly normal, healthy, and it's enough. We also get maybe slightly more around that in terms of rapid eye movement or REM sleep. And you've heard me talk about those two sleeps because they're the ones that often our Fitbits or our Garmin's or our Oura Rings, or if we have wearables, they're the ones that they tend to, if we get more of them, our sleep scores or our sleep summaries look better. But a normal kind of night of sleep looks like spending most of our time in light sleep, and that's perfectly normal and healthy. And in fact, if we didn't have light sleep, which we're easily woken from and doesn't necessarily feel as refreshing, if we didn't have light sleep, we'd probably have amnesia because that's where we do a lot of our memory encoding and storage. We know that all of these things, so the stages of sleep and how much time we spend awake, change as we get older. So when you look at people once they get into their 50s or 60s, they're tending to get having more time awake at night, less REM sleep and less deep sleep, as well as more light sleep and very light sleep. And again, that's all perfectly normal. But what tends to happen is people might start to become concerned that something's going wrong with their sleep because they're not sleeping like they were, say, in their 20s when they used to just fall asleep and forget everything and get up the next morning and it was one big continuous stretch. But it's really part of kind of everyday life, and it's normal for sleep to feel a little bit more restless as we do get older. So in summary, what normal sleep is and what our relationship with sleep has been has really evolved over history. And in today's society, we have this spectrum of enthusiasm about sleep, ranging from people who still don't seem to care and try to go by without it, to people who start to build their life around sleep and get worried about all different metrics, timing, quantity, quality, and so on. And I sense, or at least in my pocket of the world, our cultural expectations of what normal sleep are often a little bit exaggerated and inaccurate. It's not getting 8 uninterrupted hours every night. So I think that's an important message because for any people that we support or even thinking about our own sleep, it's important that we acknowledge that it's something that varies between people and that our sleep needs, we're not machines, our sleep needs do vary night to night, month to month, season to season. And so it's normal to expect sleep to be variable and have wakefulness involved, and that's perfectly healthy. One, I guess, practical or pragmatic way to think about, well, is our sleep good enough? Is this a helpful acronym that kind of means, are you sated? Sated being kind of satisfied or satiated. So the R stands for regularity. So are you going to bed and waking up at roughly the same time each day? And I think roughly is important. Again, we're not machines, so we shouldn't be trying to go to bed and wake up at exactly the same time to the minute. but people usually say, you know, if your average bedtime's around 10 p.m., perhaps the variability should be an hour or an hour and a half around that, with the exception, of course, of important life events like staying up for a family occasion or getting up early for a flight or something like that. That's all kind of part of living a life. The next one, U is missed. The next one is sleepiness. You know, do you feel alert during the day, or do you struggle with excessive sleepiness during the day? I just looked at the time and realized I'm going to need to speed up to actually talk about insomnia. Are you awake at night? Do you have difficulty falling or staying asleep? Is your sleep timing aligned in rough terms with the natural day-night cycle? You know, are you usually awake when the sun's up and vice versa, sleep when the sun's down? Sleep efficiency is a really important metric, and it's a really common focus of insomnia. Do you spend most of your time in bed actually sleeping? So a sleep efficiency score is something like if you're in bed for 10 hours, but you're only sleeping for 6, you have a sleep efficiency of 60%. And that's a really important focus of insomnia treatment, because most people with insomnia start to report quite a low sleep efficiency. And then duration, you know, note that there's no hour added to this, but do you sleep well enough to feel generally well rested and to function properly during the day? So I'm going to quickly zoom onto common sleep disorders, but I feel like the focus or the most important use of my time now is to talk about insomnia. So do excuse the quick, speedy zoom through this bit. So as well as insomnia, which is the most common sleep disorder that I'm saving till last, we often see people present with these 3 other common sleep disorders: sleep apnea, restless leg syndrome, and circadian rhythm sleep-wake disorders. So sleep apnea is a common cause for people to report that their sleep feels fragmented and unrefreshing, you know, beyond the normal expectations of that. And the reason for this is that the airway starts to collapse during sleep, which deprives the sleeper of oxygen overnight or while they're sleeping. And then eventually that low oxygen kind of sends a bit of an alarm system to the brain to wake the person up so they start breathing again, and they'll do a big gasp of air. So people who have sleep apnea are often loud snorers, and they are observed to choke or gasp during their sleep. They wake up with a headache and with dry mouth often, and they're often very sleepy during the day. And we know that being overweight, having a history of alcohol use, and having a family history of sleep apnea are common risk factors. And there's quite effective treatment for sleep apnea. There's kind of this person here is wearing a CPAP mask, which people do find quite difficult to wear, but certainly when sleep apnea is severe, it does help them feel very refreshed and function much better the next day. But for a lot of people, losing weight or having dental issues corrected or other kind of ear, nose, throat surgery can resolve the sleep apnea. Restless leg syndrome is a very common sleep disorder as well. It's common especially as we get older and among pregnant women, which is why you may have seen that little icon on the previous slide. It involves this uncontrollable urge to move the legs because it feels so uncomfortable. People talk about this itching or creeping sensation that's only relieved if they move their legs. So if they kind of jiggle them around or straighten them out. So it worsens at rest and it's relieved by movement. And you can imagine if you go to bed with this kind of sensation, it's really hard to fall asleep. So we know that people who have low iron levels, which is possibly why it's very common in pregnancy, and then some issues like kidney disease, Parkinson's disease, or other disorders associated with dopamine dysfunction, that restless leg syndrome is very common. And so there are very effective medications for restless legs, but also it might involve addressing the cause of that, whether that's iron supplements or changing lifestyles. So a lot of people that do very extreme sports often, or endurance sports, I should say, often are at risk of restless legs. The final one is kind of an extension of my night owl early bird discussion previously. Essentially, circadian rhythm sleep-wake disorders happen when there's a mismatch between someone's biological preference of when they sleep and what the external environment demands of them. So we do see it more in delayed sleep phases, delayed sleep-wake phase disorder, where people are really alert and they struggle to fall asleep until the very early hours of the morning. So it's really difficult for them to wake up in time to go to work at a typical work time and so on. So they're constantly tired and groggy and constantly kind of fighting this sleeplessness until the early morning and sleepiness in the first part of the day. We do have quite effective behavioural treatments for these disorders. And they involve kind of changing your habits over time with the help of melatonin and bright light therapy. So, insomnia, the most common sleep disorder. We know that people with insomnia essentially have too much wakefulness at night, whether that's falling asleep or staying asleep or waking up before they intend to. And that's not uncommon, but when we talk about someone with insomnia, it's when it starts to really distress them or get in the way of their ability to function the next day. It's really common for people to have short-term periods of sleeplessness or insomnia, but we know that it starts to become chronic or they kind of meet criteria for insomnia disorder if it's happening at least 3 times a week and over some time, so for at least 3 months. And these are the kinds of things that people with insomnia will talk about. So beyond that kind of broad diagnostic criteria that I just overviewed, people feeling angry or alone at night, kind of wishing that they're sleeping like the other people in their household, feeling tired and wired during the day, struggling to switch off their thoughts, nervous energy running through their body, starting to care a lot about sleep, thinking about sleep during the day, monitoring caffeine intake, buying earplugs and so on, kind of falling prey to a lot of the sleep industry products, getting worried about not sleeping and its consequences for their health, and feeling frustrated and like sleep is unpredictable and out of their control. So in insomnia literature or treatment, we talk a lot about the 3P model, which people might be familiar with either in the context of sleep or as well general kind of mental health problems. We know that if someone's going to cross over the threshold from having not insomnia to then having insomnia, say this purple dotted line is the threshold, we know that a lot of people with insomnia have some sort of risk, a predisposing factor. It might be that they have more of a tendency for their sleep to react to stress or change. We have this idea of sleep reactivity. So some people who just find they're a lighter sleeper or their sleep will be disturbed if something upsetting happens during the day. Then we talk about precipitating factors, things that trigger an episode of acute insomnia. So that could be something as simple as moving house, could be a period of stress, jet lag, having a young baby, going through menopause, experiencing chronic pain. There's a lot of things that can trigger an initial episode of insomnia. But the key point here is that over time, what keeps the insomnia fueled, what perpetuates it, this orange perpetuating factor, is not necessarily the thing that triggered it. It's not the stress or the menopause or the pain. It's factors that are really related to how the individual tries to cope and compensate for the sleeplessness and how worried they start to get about it. So common perpetuating factors involve what we've kind of discussed, so having unrealistic expectations about how their sleep should look like in terms of quantity, quality, and uninterruptedness. We talk about people having hyperarousal at nighttime, having racing thoughts, nervous energy running through their bodies. The idea of sleep effort, so people putting in more effort to sleep, which often backfires, unfortunately. There's a fear of being awake at night. So all of a sudden, waking up as per usual becomes really upsetting and causes a lot of panic. And again, these strategies that people use that seem very sensible but tend to be counterproductive. And the big one that I've underlined there is the idea of spending too much time in bed. So we talked about sleep efficiency before, and I've just noticed there's something in the chat. I'll have a quick look. Access to slides, of course. Sorry, I got distracted by that. So we talk about low sleep efficiency and people who spend too much of their time in bed awake. So if you're talking about someone who's in bed for 10 hours and only getting 6, that's 4 hours of time they're spending in bed awake, tossing and turning. And we tend to see after a bad night, people tend to sleep in or take naps. And whilst that's a kind of understandable way of coping with poor sleep, and especially if it's only been a couple of days, that might be helpful. But once insomnia becomes chronic, we know that tends to keep it going, kind of reduces the sleep drive or someone's sleepiness in the evening. And we also see this over monitoring of sleep, clock watching, counting hours. You know, I've only got this many more hours, so I can hopefully scrape by on XYZ amount of sleep. That just kind of adds to the anxiety and angst about sleep. So cognitive behavioral therapy for sleep, or CBTI, really aims to address those perpetuating factors. And I'll talk a little bit more about its content in a second. It's the gold standard evidence-based treatment for insomnia, and it's usually quite structured. It's different to just general CBT in terms of kind of understanding how thinking affects feelings and so on. There are some really specific strategies that are really targeted around improving sleep efficiency by modifying people's bedtime windows, essentially. And it's also based a lot on the science of sleep and aims to kind of correct any unhelpful ideas and myths and misinformation about sleep. So we know it's quite effective with some quite simple strategies. And we know it's also effective across people with different types of problems, whether they be mental health comorbidities, chronic health conditions, or people who are in older adulthood. So we know that after CBTI, people report taking less time to fall asleep, their sleep efficiency improves, and perhaps most importantly, their self-reported insomnia symptoms, so how worried and distressed and how dysfunctional they feel their sleep problem is causing them, we know that they report improvements. I think it's really important to emphasize that CBTI is not sleep hygiene, and we actually know that sleep hygiene in and of itself is not an effective treatment for insomnia. In fact, it often becomes part of the unhelpful sleep effort. So I see more commonly that people with insomnia, especially in the face-to-face setting I work at, do sleep hygiene way too well. They never have coffee, for example. They never eat chocolate. They've got very rigid wind-down routines. They don't go out at night anymore because they're so afraid that it might interrupt their sleep. It's also not just a selection of thinking tricks to switch off a busy mind at night or kind of a relaxation program to achieve calm. All of those things have this same idea of putting too much effort into sleep. CBTI is rather treatment that targets the factors that keep insomnia fueled, so anxiety about sleep, spending too long of a time in bed awake. So it's strategies to improve sleep efficiency and to consolidate sleep, and to help people cope and manage after a bad night, which is often the key fear about insomnia. So one of the really challenging things about CBTI is that we have this amazing body of evidence. We've got nearly 250 trials to show that it works well, but there's not much implementation. You know, at least in Australia, I didn't get training in CBTI when I did my kind of postgraduate clinical training. And we know that's because up until the most recent diagnostic manual for mental health and sleep disorders, insomnia was always seen as secondary when someone had something like anxiety or depression, for example. And the idea was that if you treat the depression, for example, the insomnia will go away. But we know that actually insomnia gets stuck in a very vicious cycle with mental health problems. And in fact, if you treat the insomnia, you will get better mental health outcomes. And often if you just treat the depression or the anxiety, that the insomnia may stick around, and we know that that risks relapse of the mental health problem. But we do have this kind of delay in terms of getting health professionals and clinicians access to CBTI training. So digital CBTI is a really useful way to kind of help overcome this workforce shortage. And I've attached here a little snippet of the sleep course, which was the kind of development trial of the course that's available at the OTU. And we saw that it was helpful in a very diverse and pragmatic sample. So people who did have comorbidities and chronic pain and other sleep disorders and so on. And we hope that it helps to kind of redivert the large majority of people who end up using prescription medication instead of accessing these effective long-term behavioral strategies. So I was going to talk a bit about what's in the course, but I'm aware that I'm only leaving 4 minutes for questions, and I can direct you to that paper, or I can answer it in question time. So I might stop there. And thank you for your attention. And I might pass it to Emma to facilitate some brief Q&A, noting that I'm available via email if anyone has other questions.
I was thinking it might be helpful to show that one slide just quickly before we do the Q&A.
Yes, sure, Heather.
Yeah.
Yep. Okay.
And then I'll leave it to everybody else.
So the sleep course has 4 lessons in it, and there are some additional resources as well. So the first lesson provides some really helpful psychoeducation about insomnia and some of the influences of insomnia, and goes over some of the science of how sleep is regulated. There's a little bit of a few tips about sleep hygiene, as well as some newer things that people are less familiar with, like the sleep pressure system. There's a myth-busting resource that actually covers a lot of those myths that I busted earlier in the talk. The second lesson really talks about some of these sleep efficiency boosting strategies. There's two different types. One's called sleep restriction therapy, which has terrible branding but super effective, and stimulus control therapy, which some people are more familiar with, the idea that it's important to use bed only for sleep. But sleep restriction therapy essentially involves kind of shortening the sleep opportunity for a short term so that people start to have more consolidated sleep within a smaller bedtime window, and then gradually widening that window again, and it can be very effective. We then talk about kind of the role of unhelpful thinking and the cognitive aspects of insomnia that might be keeping people awake at night, or even kind of perpetuating their daytime distress. And then the last lesson goes over some of the unhelpful behaviors that we might be doing to maintain our insomnia during the day, like avoiding things, staying inside, not getting sunlight. We talk about how to cope with a difficult night, schedule a day of activities that might take into account tiredness from previous night, but also encourage people to stay active and manage fatigue best they can. We also introduce people to some helpful kind of routines to start their day and to end their day. And there's a whole range of associated resources as well that answer some common questions that people have. So we actually have a new one as well that we've developed that I know is at the OTU about prescription medications, which is a common question or common area of conversation people have. Talk about shift work, nightmares, as well as if people do identify with being very wound up at night, some relaxation strategies too. All right.
Great, thanks for going through that, Amelia. We have a couple of questions if we can sneak them in.
Yeah, I have nothing on after this, so maybe if people have something else to go to, they can, but I'm happy to stay and answer questions.
Okay. Great. So one of the questions here is, is the sleep course therapist assisted? Any evidence on whether therapist assistance improves outcomes?
That's a great question. So when we offered the course, it was available with clinical guidance, and about 40%, 30 or 40% of people worked through the course while they had guidance. We have no comparative trials, to my knowledge to date, comparing guidance without guidance with CBTI specifically, but we do know in other areas, so other kind of online treatments, that having some degree of clinical support can sometimes help improve outcomes for people. But it's very case by case. And we find with the sleep course, we involve a lot of messaging and emails to help people feel supported and encouraged, even in the absence of kind of verbal contact or messaging contact with people. So people generally feel guided and supported, even if they're not talking to someone live.
And at the online therapy unit in the sleep course, you would also receive those therapist messages. So once a week, you would get a message from them. So they would help provide guidance throughout the course as you're working through the material. And then they can also answer any questions that come up as you're working through it. So another question here is, can you still do the course if you are working with a therapist on other issues? So I'll speak to that. You can still take the sleep course at the online therapy unit if you have a therapist working on doing some general counseling. The application process would go into details of that just to get a bit more information. But yes, that would be fine, totally fine participating in the sleep course. Let's see. Another question here. If someone wants to do the well-being course and the sleep course, is there a particular one to start with?
Do you want me to answer that one?
Sure. Yeah, sure.
I would leave, because it's a common question that's come up as we've implemented this course into another digital service. I believe that if you're talking with somebody about which to start with and they feel like they have a sense of what's causing the most problem for them, then it would be worthwhile starting with that first. We have no evidence that treating one disorder over another is kind of better in the long term, or kind of addressing mental health issues before the sleep or vice versa. So if someone's saying, look, I actually feel like my poor sleep is going to be the biggest problem to solve, then I would just pick what kind of is more aligned with the person's working model of their problems and what they feel is the biggest priority.
Another question here. What are your thoughts on the utility of smartwatches for tracking sleep? Does it help or hinder? Are they accurate?
So smartwatches, the science of them, especially the ones that are more sleep focused, they are getting more and more accurate with every new phase and iteration and version. They're very good at detecting if you are asleep compared to if you are awake, in general, but they're not phenomenal at testing what different types of phases that you're having or stages that you're having. We know that the accuracy is kind of leaves room for improvement. I'll just say that. In the context of people with that, who are on that anxiety end of the spectrum, who are very concerned, who monitor their sleep, who get their sleep scores, and the scores are never perfect, I think it can create a bit of unhelpful perfectionism. But then for some people, it's a helpful nudge to make sure that they're giving themselves the right opportunity. So it's very case by case, but I do think that in general, kind of they are part of this culture of perfecting and optimizing sleep. And I'm not sure that overall it's been very helpful, at least for the people that I see who come through my clinic and who come through the sleep course.
Someone asked to receive the sleep and shift work additional resources. And so those additional resources are actually part of the sleep course at the online therapy unit. So if you take part in the sleep course, that's where you would gain access to those additional resources. Another question here, can you speak to sleep meds, long-term use, getting off, etc.?
Yeah, so sleep medication, and I'll kind of keep it to prescription sleep medication. There's a lot of different drugs with different mechanisms of action. So some of the common ones are things like the benzodiazepine, the anti-anxiety drugs, as well as some kind of other sedative hypnotics. So we've got our brand names for them, as Stilnox, so kind of Zolpidem or Zopiclone. People also are often prescribed things like antidepressants or even antipsychotic medication off-label. So in Australia, we know that most people with insomnia have prescription sleep medication rather than access to this type of treatment in the sleep course, even though we know that this type of treatment is as effective in the short term and then more so in the long term. I think it's difficult because a lot of sleep medication, especially the older ones, aren't meant to be used for more than a couple of weeks in a row. But we know that a lot of people do end up having a pattern of taking sleep medication long term. And there is two aspects. I guess there's a physical dependence that might happen that requires very slow tapering off, as well as the kind of psychological aspect of kind of slowly losing confidence in sleep over time. But what we generally encourage to people who have some sort of relationship with their sleep medication is to learn the skills and strategies and the information in a course or a CBTI treatment like the sleep course before gradually tapering off with supervision of a health professional. And especially if the kind of sleep medication is more of a tolerance forming medication that's been used for a long time, it's often about going really slowly and gradually, because we know that does often, going off quickly, it can often result in rebound symptoms that are quite unpleasant and severe.
Two last questions here. One of them I'll answer. Is there any way for someone in the province of BC to take the course? So the sleep course is only available to those living in Saskatchewan. It's for those 18 and over living in Saskatchewan and who have access to the internet and a device, because it is entirely online. What you can learn more about the sleep course and the eligibility criteria at our website, which I'll put in the chat here. But yes, it is only for Saskatchewan residents at this time. Another question here, are there evidence-based resources for sleep problems among those with ADHD?
I've been getting more and more questions about sleep and neurodiversity, and more people come through the doors of our clinics with ADHD or ASD or other aspects of neurodiversity. And I think the research is trying to catch up with that. We certainly have had people through the sleep course with ADHD who've responded well. And there's a growing area of research kind of looking at sleep differences and potentially the role of melatonin, as well as the role of the medications for ADHD and timing them appropriately and making sure that they're not interfering with sleep. I'm not super familiar of any actual resources, but it's kind of been something in my mind for a while to add into the sleep courses. It's becoming a very strong area of unmet need.
I think our last question here, would the sleep course be appropriate for first responders who do shift work that operates on irregular schedules? I see there is a resource addressing shift work. However, would any of the main core skills be difficult to implement in this context?
Yes, we do have a resource on shift work, and some of the skills and strategies in the course require some modification and creativity. So some of the kind of setting regular bed and wake times, for example, and a bedtime window needs to be considered and kind of dealt with a little bit differently. But there are also aspects of the course, aspects of, using the science of circadian rhythms to promote good sleep in the context of shift work. And we also, in my opinion, when I've worked with people whose day-night patterns tend to change for work and other reasons, I think it's just about redefining where our sphere of influence is and talking a lot about, a lot of people still have distress about not sleeping well. And we just try to identify the barriers that are getting in the way of them either sleeping well at night or feeling rested during the day. We find ways of kind of helping somebody, even if they have challenges with shift work. There was also a question about first responders, and I think that's an area of collaboration that we might even be going into. I guess in the context of first responders, where there might be a degree of stressful and traumatic experiences, there might be some ways of prioritizing strategies around nightmares or hyperarousal before we talk about the sleep. Yeah.
Great. I think those are all the questions here. I just wanted to give everyone a little bit of information about how you can get started in the sleep course at the Online Therapy Unit. So you can head to our website, onlinetherapyuser.ca, and learn a bit more about the details of the sleep course there. And then that is where you would fill out an online application. It'll take about 20 minutes of your time and asks questions about how your sleep is, what sorts of things are happening now that might be affecting your sleep. And then once you complete that online application, you would speak to one of our staff members over the phone just to ensure that the course would be an appropriate fit. And then you would be given your login information to access the sleep course on our secure website. You would also be matched with an online therapist who will help guide you through the course. And you'll have access to the material. So it is an 8-week course. There's 4 lessons, but it takes about 8 weeks to complete. If you do have any questions about how to get started in the course, you can send us an email or give us a call. And all of our contact information is on our website there. But yes, you don't need a referral from a doctor or anyone to get started. It's all available to the public online. So thanks so much, Dr. Scott, for your time today and for presenting to us, especially with the time change. We really appreciate you taking the time this morning in Australia and this afternoon in Saskatchewan here.
It's a pleasure. I'm sorry to have talked a little bit too long. I just put my email as well in the chat. If anyone does want to get in touch with any further questions or requests for resources or anything, I'm very happy to respond to questions via email.
Great. Thanks so much. And thank you everyone for joining us. Have a great rest of your day.
Bye.